I'd like to join with others in acknowledging the traditional custodians of the land upon which we meet today. My job is to introduce my colleague Stewart McDougall, who's waiting in the wings there keenly, who is an early career researcher at our centre. And that's my great pleasure. But before I do that, and Stewart and I have worked on quite a few projects together, and Stewart has presented on some of our projects as far afield as South America and as close to home as Brisbane at the first inaugural Fetal Alcohol Spectrum Disorder Conference in Brisbane. So we've worked quite a bit together over the last couple of years, so it's a great pleasure to introduce him. But my other job is to provide a little bit of the context for the program of research that Stewart's study is about, sits within, and that he's going to be talking about today. So basically, the program of research that this study fits within is around the support needs of children who are placed in out-of-home care, a critical exploration and critical evaluation of what those support needs might be, asking questions like what might be the impact of early life adversity, exposure to alcohol before birth, early interpersonal trauma, neglect, what's the impact on the development of the child, what might be the neuropsychological impact, what does that mean for their behaviour, and what does it mean for their potential to experience a stable family-based placement. And how can we optimise their chances of having that experience if they need to be placed in out-of-home care. Before I go on to introduce Stuart, I just want to highlight the significance of fetal alcohol spectrum disorder for the out-of-home care sector and for children who enter out-of-home care. To me, if a child's entering out-of-home care and they have been exposed to alcohol before birth, to a damaging degree, it's really like they're entering care. It's like a perfect storm of risk factors around them, in a way setting them up to a trajectory of negative outcomes. Our sense is that it's less likely for them to be able to reunify with their biological parents, perhaps because parents have ongoing alcohol issues and aren't able, alcohol dependence issues, and aren't able to provide the high levels of routine and structure that children with fetal alcohol spectrum disorder may need to thrive. It may be that the neuropsychological issues that they have developed mean that their behaviour is challenging in situations of transition, situations of change. They may struggle with organisation and planning. They may struggle with memory, language, and they may not be as responsive as other children to our conventional parenting approaches. And many aspects of our system really are mismatched to their needs, and I think you've touched on that as well. So for a number of reasons. And the other thing I wanted to highlight just before we go to Stuart's presentation is that a recent paper that's come out that's actually highlighted exactly how prevalent fetal alcohol spectrum disorder appears to be in the out-of-home care sector. A paper published in Paediatrics, a review and meta-analysis of the prevalence of fetal alcohol spectrum disorder in a range of out-of-home care settings, has reported that 16.9% of children across a range of out-of-home care settings, on average, are identified as having some form of fetal alcohol spectrum disorder. So it's a very significant issue, and that may present without any physical symptoms at all. So this makes the kind of work that Stuart's presenting on today very, very significant for those of us who support children in the out-of-home care sector. So Stewart is an early career researcher, who will be talking about his work in the area of interventions for children who have been affected by prenatal alcohol exposure. So he joined our team as an as a summer scholar back in 2011 and stayed on and did honours with our team, and now is a valued team member as part of our research team. So please join me in welcoming Stewart.
Thanks for that introduction, Sarah. Before I get started, I'd just like to acknowledge that we meet on the lands of the Kaurna people and pay my respects to elders past and present. So, as mentioned, my name's Stewart McDougall. I'm an RA with the Centre, and I'm going to talk about a piece of work that we undertook which explored interventions for children with fetal alcohol spectrum disorder. Throughout the presentation, I'll probably swap to calling it FASD, which is a bit of an Australianism. But whenever I say FASD, I'm just cutting it down from fetal alcohol spectrum disorders. This is even more significant as today is also International Fetal Alcohol Spectrum Awareness Day. It happens on the 9th of September every year. A bit of a coincidence that it falls today. In the first few slides, I'll provide some background into fetal alcohol spectrum disorders before getting into the results of our systematic search. So what is fetal alcohol spectrum disorder? It's the spectrum of physical, cognitive and/or developmental symptoms that are caused by prenatal alcohol exposure. It was first recognised in the late 1960s and early 1970s in the medical literature, where it was coined Fetal Alcohol Syndrome. There has been much work done since this time, and it's now recognised that it is a much broader spectrum of effects than fetal alcohol syndrome, which is the most severe and most visible of the fetal alcohol spectrum disorders. An accurate prevalence rate is not known for Australia. There are a few barriers to the diagnosis of FASD, which affects our ability to have a strong prevalence estimate. Some of these barriers that have been noted by previous researchers are a reluctance to diagnose, given a perceived lack of available interventions for children and families living with fetal alcohol spectrum disorder, and the data required to diagnose is typically not collected routinely. So while an accurate estimate is not known in Australia, there has been reviews of studies conducted in the United States and in Western European countries, which suggests a prevalence rate of between 2 and 5% in the general population. That's for fetal alcohol spectrum disorders as the umbrella term, covering a number of diagnoses. It's a much smaller subset of fetal alcohol syndrome, the more severe and visible end, which makes up less than 1% of the 2 to 5%. As mentioned by Sarah, there are some populations which are at risk of higher prevalence, including the out-of-home care sector and youth offending and juvenile justice programs. So what is different about the way children with FASD may behave? So the impact of prenatal alcohol exposure affects a wide number of structures within the brain and can present with difficulties across a number of areas. So they may have difficulties with executive functioning, which is the coordinated planning and execution of behaviours, so thinking ahead, planning, and that sort of behaviour. I won't go into it in too much detail. They may have memory difficulties, language difficulties, delays in gross and fine motor function, disordered attention and activity levels. There's quite a big overlap between FASD and ADHD. They may have delayed attainment of specific academic skills, and the overall IQ may be lower, although this is not always the case. There's quite a wide variation in IQ as well. So while it's quite a long and complex list of challenges they may present with, it can be more useful to think of how these deficits may present in children living with fetal alcohol spectrum disorder. So the memory problems, they may have trouble learning something, they may remember inconsistently, so they might learn something one day and forget it the next. Their language difficulties, they may be talkative but understand little of conversation. They may have other difficulties with non-literal language, so the use of metaphor, figurative language, they may especially struggle with that. They may have little understanding for the social conventions of conversation, so little understanding for turn taking. They have a slower cognitive pace, So they may only understand instructions when given to them slowly, and they may miss pieces of information. They may have trouble translating information gained in one setting to another, so they may have trouble translating information and learning from, say, a therapy room into the home, into the school, so that can have significant implications for continuing interventions across different settings. They may repeat the same mistakes. They may be unable to learn from their mistakes and to predict consequences. And lastly, they may have trouble thinking in the abstract, so setting goals, thinking about time and money. There may be difficulties for these children. So these challenges that children living with FASD, they can continue throughout their life, and as a result of these challenges, they have a poor fit with their environment, and this poor fit leads to what are known as the secondary symptoms. So these are the adverse life outcomes that children with fetal alcohol spectrum disorders may present with. So there are increased risk of disrupted schooling, trouble with the law, alcohol and other drug problems. There's a high comorbidity with other psychiatric disorders. And as mentioned a couple of times now, there's also an increased risk for involvement with child protection and child welfare. In terms of protective factors against these negative life outcomes, early and accurate diagnosis has been identified as one, as has being raised in a stable and nurturing environment. And lastly, the provision of appropriate services is another protective factor. So given the wide range of challenges and the importance of intervening effectively early, we sought to answer the question, what is known about helping the children with FASD and their parents and caregivers. Our approach was to conduct a systematic review of the literature, examining the published studies of interventions for children living with FASD. So the searches were initially conducted in July 2013, returning about 750 articles, which were all screened at the title and abstract to see what was relevant in those. From those, that was distilled down to 17 articles which reported an intervention for children with FASD. I excluded studies which were pharmacological, so studies where they'd tried drugs or nutritional supplements, and I'd excluded case studies, so where a single child was reported. I updated the studies in August in preparation for this event, and one additional study was located. So in total, there are 18 studies covered in my reviews, and these 18 studies reported 15 independent samples, so 15 different groups of children, and examined 11 different interventions. So that's quite a broad range of interventions that are tested for a relatively small body of literature. Now, this wonderful large table with a wealth of information on it, we've got all of the interventions that have been tested in this column here. So as you can see, there are a few interventions which have been tested by numerous authors. So we've got the ALERT program, children's friendship training, the maths interactive learning experience, and the parent education workshops. Although it's called a different thing, the parent education workshops were incorporated as a component of the MILE program. We can also see that there is a broad range of different sort of therapeutic tools used. We've got studies that used video games to teach the children safety. So these used video games where the child would be led around and have a dog in the virtual world explain to them the correct procedure for crossing a road, and the child would follow the dog and play the games until they had learnt that behaviour and then could generalise it to the real world. So there was both crossing a street safely and what to do in case of an emergency that was tested using the video game. There's also language and literacy training where children worked with a speech therapist just to work on the building blocks of their language. There were also, the promising practices was a sort of a different intervention as it focused on one region as opposed to one group of children, and all children in out-of-home care in that region received an extended support, which was shown to be quite effective in improving their stability. So whereas there are some studies which are quite small targeted interventions, there's also studies which are focused on a much larger region. I'm going to talk in more detail about the few studies that have been tested in two populations. So we've got the ALERT program, children's friendship training, and the maths interactive learning experience and parent education workshops. So the children's friendship training, as I mentioned, was tested in two quite large samples for this body of literature, tested with 185 children in total, and it used a group format, so children with FASD were brought together, including their parents and caregivers who received similar information received in a parallel group. So the children would come to therapy and have their group working with the therapists, and the parents and carers would be in another group learning parallel material on how to support the child with continuing that intervention in the home and school space. It was shown to be quite effective in increasing the children's knowledge of social skills, the parents' ratings of the child's social skills, and in reducing the parents' perceptions of the child's problematic behaviour. It's important to note that teachers' ratings were also sought for these children, but there was no similar drop in the teacher's perception of the child's behaviour. So the teacher perceived them to be as disruptive in classes before the intervention as they were afterwards. The gains that the children made were also maintained for 6 months after they finished the intervention. So this is one of the few studies that shows that it is improving their social skills and behaviour over a longer time period. The ALERT program was a neurocognitive rehabilitation program. The therapists use the metaphor of the brain as a car engine, and children are taught to recognise when they're in high gear, so when they're a bit worked up, a bit hyperactive, to recognise when they're in low gear, when they're having trouble getting started on a piece of work, and to recognise when they're in just right gear for the situation, so where they need to be for what they're doing. In addition to teaching them to recognise where they are, they also equip them with skills to help them self-regulate a little bit more. Again, this program, in addition to the group sessions for the children, there were also parallel sessions for the parents to ensure the continuity of that intervention in the home. The results showed that the parent ratings of executive functions, which were one of the outcomes in both studies, the parent-rated executive functions improved as a result of the intervention. In the second study in 2014, it was a small sample, and they measured the executive functions using laboratory tests as well, so things like the NEPSI or the Tower of London tasks, where they sit the child down and get them to work through a task to test their executive functions. They noted a trend level increase, so it didn't quite reach statistical significance, but it still improved, and it's probably due to the small sample of only 25 kids that were involved in that intervention. So it shows promise for improving things on an objective measure, not one that's rated by the parents. They also noticed trend level improvements in the parents' perceptions of the child's problematic behaviour as well. The final set of interventions I'll talk about was the maths interactive learning experience. So in the early stages of this intervention, all of the families were invited to participate in two-hour workshops. One of the workshops taught parents and carers about fetal alcohol spectrum disorders and how to advocate for their child within systems, and the second taught the parents skills to help regulate their child's behaviour. So all of the families received that intervention, and then the families were split up into children that would receive the maths interactive learning experience or just a standard tutoring intervention. So the maths interactive learning experience taught the children maths on an individualised basis, so they were taught things that they were really struggling with. They also used a number of environmental accommodations, so that's the slowing down how information is presented, providing them with tactile tools to play with so they can visualise how something is changing. So instead of just seeing numbers on a sheet, they've got number ladders so they can see numbers going up and numbers coming down as they add and subtract. The children who received this intervention showed gains in maths directly following the interventions, and 6 months later they were shown to show greater gains compared to the group that received the standard tutoring. So over that 6 months they'd improved more than the children that didn't receive that. So it's a really strong demonstration of the effect that can have. The mild component was only tested in a single sample of children. I've included it in the studies that used 2 samples as the parent education workshops were tested a second time. So they compared the effectiveness of the in-person 2-by-2-hour workshops to presenting the same information online or through handouts. And again, they were shown to be quite useful for parents. Parents were very satisfied with them. They felt that they could take away what they'd learned and help to work with their children to reduce some of their problematic behaviours. So those 3 represent sort of best bets for various domains in which children may have difficulties. More research is necessary, which I realise is not a very helpful thing for me to be up here and say, but yeah. So more research is necessary because there are few interventions which are tested in multiple samples. There is a broad range of areas in which children can have challenges in their lives, and yeah, there's only a small number of interventions which are tested across different samples. Importantly, there were no Australian intervention studies identified. Australia is typically not recognising fetal alcohol spectrum disorders particularly well. We're lagging behind, particularly Canada, but there is work being done to remedy this. There are a few fantastic organisations out there, such as No FASD, who are pushing for awareness. In terms of sort of take-home messages from these interventions, there were common elements which came out, which common principles of how the interventionists work regardless of sort of the behaviours they were targeting. So education for parents and caregivers about fetal alcohol spectrum disorders, reframing the child's behaviour in terms of this is something that they can't do because of the damage caused by prenatal alcohol exposure. So reframing it to an understanding of something they can't do rather than the willful disobedience, especially because there are very few visible signs for some of the fetal alcohol spectrum disorders. They don't show the characteristic facial features of fetal alcohol syndrome. As I mentioned in the Maths interactive learning experience, they used verbal and non-verbal presentation of information. There were quite a few interventions that used that to good effect. Material broken down into simpler components, and sorry, got an extra space there, I shouldn't have one. So not only broken down into simpler components, but the use of simpler language and avoiding the use of metaphor and figurative language. Multiple exposure to the concepts and repetition of those concepts to help the child learn and remember. The use of video games is a great example of how that can just be repeated. If the child is just happy to play the video game, they'll just play and play until they've sort of learnt the principles that the video game's teaching. And the provision of immediate feedback regarding the child's errors. If the feedback's delayed, they may not make that association between what they've done wrong and, yeah. So in terms of limitations of the review, the biggest one is, of course, a publication bias. So in reviewing published literature, I'm limited to what has been published, and journals are likely to only publish things that find an effective result. So there may be studies out there which have been conducted but haven't been published because the interventions they're testing weren't shown to be effective, and a null result is just as important as finding something that is appearing to be working. One example from this was parent-child interaction therapy, which suggests that problems arise in the interaction between parents and their child, and this was tested with one group of children, and it was shown not to be any more effective than a support program just working with the parents. The authors suggest that because of the brain-based nature of FASD, that therapy misses that important brain-based aspect. In terms of future research, multi-component interventions looking at a few different aspects individualised to where the child themselves has difficulty will be very helpful going forward. And of course, longitudinal studies to see what is effective in preventing the secondary symptoms, so that's the adverse life outcomes that children may have. The longest follow-up in these studies was about 6 months, so there's no way to know if that 6 months of follow-up where they've shown gains is improving their schooling outcomes or improving their life outcomes beyond that. Just before I finish up, I'd just like to give a plug for a webinar that Dr. Sara McLean and myself will be running. I think that's been pushed to December now. Unfortunately, it was meant to be next month, but that's being run through AFS, is it? AFS? The Australian Institute for Family Studies. Thank you.